Hello, Joel Dunning here, and I'm absolutely delighted to be joining on the podcast an amazing innovator and person, Mr. Fraser Sutherland. You are a wonderful and senior consultant cardiac surgeon at the Golden Jubilee, but you are so much more. You are an innovator, and I'm so excited to hear that finally, after many years of innovation, a robotic transcervical aortic valve replacement has been finally performed. So I would love to hear from you how this came about from the seedling of the first thought all the way to a clinical case, and of course, what the future entails. So thank you for joining, and yeah, tell us about this incredible project.
Well, thank you very much for that very warm introduction, Joel. I guess when I look back, the story starts in the late 80s, would you believe, when I was a medical student and I did my elective at the Toronto General Hospital, which at that time was one of the probably still is one of the leading centers for thoracic surgery in North America. And at that time, in a lot of centers, thymectomy was performed as, a full sternotomy procedure, rather like heart surgery. But in Toronto, the surgeons were doing this through a little incision in the neck, transcervical thymectomy. And with that change in procedure, they transitioned an operation from which, recovery was a week in hospital and maybe a few months for recovery out of the hospital to a day case procedure. And years later, I had this idea that maybe if we could do heart surgery through the neck, like this, through transcervical incision, that we could transition heart surgery from a week-long in hospital and 3-month recovery to a day case procedure. Well, we're not quite at day case procedure, but we've certainly come a long way and very close to that, I would say, at this point.
Yeah, so obviously the 80s you thought about it, but actually you went further. We all think of ideas, and it's simple to think of an idea, but actually getting this into practice is really difficult. So what were those next steps you took towards trying to make this idea a reality?
Well, as you say, getting into practice is quite a challenge. And one of the sort of immediate challenges was that for transcervical thymectomy, Dr. Cooper and his associates used a very simple retractor system. But heart surgery, in particular aortic valve replacement, which was the kind of target procedure that we chose, is a little bit more complex. And we felt needed a technology and an approach that was a bit more than just simple retractor. So we developed this Corvista transcervical retractor system, and this incorporated firstly a retractor with a set of lights that illuminate different zones of the field in sequence with the steps of an operation. So I have a little light to illuminate entrance to the incision, and then that light would be extinguished so that the surgeon's not exposed to glare. And there would be a second light setting that illuminates structures inside the chest, and then a third light setting once the aorta was opened that would shine down the inside of the aorta. So this was the Corvista retractor, as we called it. Another element of the system was visualization because, in the early days, people were doing surgery looking at a screen in the corner of the room. Or off to the side, because obviously the patient's right in front of you, you're working from the neck. So we decided to bring a screen into the surgical field within the direct line of sight of the operator, because we know that having the screen positioned in this way increases the speed and the accuracy of your motor movements. And with this combination of features, we felt that aortic valve surgery was going to be feasible. After many years of development work, we did first clinical cases in South America. And at that time, we were using the mix instruments, the long shafted, minimally invasive cardiac surgical instruments. But we were doing it through this incision, which was effectively a uniportal incision. And, as you can imagine, because I'm sure you've got a lot of experience of uniportal surgery, it's actually quite difficult. So that was the next obstacle. So we were able to do cases successfully, but it was quite difficult. In, I think, 2022, after COVID or just after COVID, I had this idea that maybe we could bring more dexterity to the surgeons by incorporating a robot into the equation. The other challenge, just whilst we're on that sort of subject, was that the cardiac surgeons, they weren't really very familiar with this approach from the neck, and they could kind of see that you could get to the aortic valve, but they couldn't understand it because, the anatomical textbooks really teach anatomy quite separate. Neck anatomy is quite separate from chest anatomy. So we did two things. We brought a robot into the equation, and we also teamed up with some thoracic surgeons, yourself, of course, and one of my esteemed colleagues, Rocco Blanchia. As you know, we came down to your hospital, and we did the very first exploration on in a kind of dry lab setting to see what it might look like. And I'm very grateful to you and your fellows that day for accommodating me and getting us started. Then after that, we came back to Glasgow and did a bit more work trying to figure out each of the steps of the operation. Because like every operation is a series of steps. So we looked at each of those steps and we tried to envisage a model how we would do those. The robotic instruments are quite different to the conventional instruments, and there is a lot of utility in them that we need to learn about. And then, having figured that out, we wanted transition to the next step was to do the same thing in cadavers. And we were lucky enough to get involved with the University of Illinois in Chicago and their excellent facility that allowed us to bring a Da Vinci Xi robot to the side of a cadaver. And we did a series of cadavers with some US surgeons, Sam Berkey, who's well known in the cardiac surgical community, and Danny Ramsey, and of course, myself and Rocco went out there as well. Pretty much we were able to perform the operation through the neck as we'd planned right from the start. And, the first case went very well, and then the subsequent cases were almost identical. And this really encouraged me into thinking that this was possible. So that was the preclinical work.
Yep. So, and then you took that giant leap. How did you get from that preclinical work to a real actual case in one of the most litigious countries in the whole world? How did you take that incredible leap?
Well, for various reasons, we thought we had to go to America, and I guess that's a separate discussion. But anyway, we decided to go to America, and we spoke with a number of surgeons. The kind of pivotal moment was actually at AATS in Toronto, and I met with Dr. Lars Svensson, who, as you know, is president of AATS and chairman of department in Cleveland Clinic. And we had a chat on the elevator. I did my elevator pitch, as they say in the entrepreneurs world. And at the end of that, when we stepped off the elevator, he gave me one of his colleagues' name, a guy called Marian Koprivanic. So after a few months, I suppose I should have done it earlier, I suppose. But anyway, I contacted Dr. Koprivanic. We had a little call. I was traveling in China, and he got on the call, and he had just done two back-to-back aortic dissections, which super impressed me. And despite all of this, which would of course have wiped me out entirely, we spoke for about an hour, and at that point, I knew this is the guy that's going to do it. So we did a lot more prep work, of course. It wasn't just as casual as that. We did a lot more work on the cadaver, and he himself did some own work with his team, training them on the cadaver. And we did the first clinical case finally on 28th of February.
Yes, absolutely fantastic. So maybe just tell us a little bit, how did that first case go and how was the patient?
Well, the patient did very well, actually. So the main focus of that case was safety. We absolutely wanted to do a perfect operation and mitigate all possible risk. So to Dr. Koprivanick's credit, at each stage in the procedure, we'd sort of step down and he'd talk to the team about, what the next step is, and if this doesn't go well, what our backup plan is. And the procedure went very well. Patient, I think, was discharged after a couple of days and was meant to attend follow-up at the end of the week, but actually got on a plane to Florida. So, so I take from that she did pretty good. And then since then, the focus has shifted a little bit towards, trying to standardize the procedure, get cross-clamp time down, and those of course, patient safety as well. But to try and get the cross-clamp time down, and as I say, standardize the procedure. He's done about 10 cases now, and the general sort of theme has been that patients experience very little pain from this incision, which of course would be no surprise to you as a thoracic surgeon, but of course excites the cardiac surgeons. And firstly, and secondly, that patients have been discharged as early as second day after surgery, even this early in the experience, so really, really incredible to see those patient benefits that we had always sort of envisioned being sort of validated in real life cases.
Yeah, I mean, that's absolutely incredible. And you often hear about, I mean, as a thoracic surgeon, we hear about cardiac surgeons doing minimally invasive surgery through a 10 centimeter right thoracotomy, and we roll our eyes and we go, that's not going to fly. But actually, this genuinely is an amazing development. So I've done some transcervical thymectomies. They just have no pain. And so, this is no cut in the sternum, no cut in the chest. So you don't have a painful thoracotomy as well as no painful stenotomy. So this absolutely looks like a real game changer, really impressive, especially when we're fighting so hard against TAVR. It looks like an amazing development. So, where do we go from here then?
Well, of course, it's great to get the first cases done, but I think, it's only really going to have an impact on the world once, more surgeons start to do this. And once we get the procedure, I use this word standardized, but you'll know what I mean. There are sort of tips and tricks that we incorporate into our surgical procedures that are just second nature, but they have to be worked out. So that's our sort of next challenge is to get a few more surgeons involved. And what I saw from the development of TAVR really was that when a lot of physicians get together and focus on problems, those little problems can be easily solved. So that's the kind of next phase. And of course, we don't want to just do aortic valve replacement. That's the kind of beachhead procedure, if you like. We're looking to do much more complex procedures, like root replacement, replacement of ascending aorta, and other sorts of procedures that, are in some ways quite attractive to the kind of robotic approach. They wouldn't have been feasible with using minimally invasive, conventional minimally invasive instruments, but with the dexterity provided by the robot, I really think that these things are possible. We did a little bit of exploratory work once again in Chicago in the cadaver lab and showed that we could do a root replacement. Of course, it took a little while, but it's there, it's possible.
Wow, that's absolutely amazing. And maybe let's geek out a bit with the details because there might be some surgeons bouncing with excitement to join in. But so presumably it's fem bypass, cervical incision. I think you have one extra incision for a third arm. Is that right? So maybe tell us a little bit about exactly how you do this procedure.
Yeah, so we elected to have a peripheral bypass. Actually, first patient had axillary bypass, but we used that same incision for one of the ports, actually. But yeah, basically fem bypass for the access is relatively straightforward and quick onto the aorta, which is then immediately in front of you in the field. It's an axial approach. The cross clamp comes in from the side. We use chipwood clamp, a little bit different from the kind of mitral situation where it doesn't really matter where you place the clamp across the aorta. In the aortic situation, you need a decent length of aorta to be working on. So you're able to dissect between aorta and the main pulmonary artery with the robot very nicely. And then they have this nice tool they call tip-up dissector, which you'll be familiar with, which was a new one to me. And that goes nicely around the aorta, which clears a nice
Yeah.
space, and then you can get the clamp across the aorta.
Mhm.
Once the aorta's clamped, we use this del nido cardioplegia to give us a decent length of time to work on the valve. But top-up cardioplegia can be delivered directly into the coronaries very easily with the robot, actually, once the aorta's open. Another key aspect of the procedure, we make a longitudinal aortotomy, interestingly. This provides us with a better exposure than a transverse and also is much easier to close because you're sort of working towards yourself. And then the details of the procedure itself, you excise the valve with the robotic instruments. There are some little tips and tricks for doing that because it's quite calcified. And then we have two kind of approaches. I had always envisioned that this would be a natural for a sutureless valve because you're on axis, it's a straight shot. But Dr. Koprivanic has shown that actually you can suture a valve in this way, and that has been his preferred practice. So he has developed this kind of semi-continuous technique, which, some of the surgeons, particularly down south, will be aware of in open surgery, which can be a little bit of rigmarole, parachuting down, pulling up loops and things. But in the robotic situation, once again, slightly different to open surgery. The valve is quite close to the annulus, and actually, it's actually quite well adapted to the robot. And then he just plant three core knots at the three commissures because no one likes to tie knots these days.
No, we know that. Yeah, I suppose it's yeah, reducing time's really key, isn't it? But I guess the advantage of doing a sutured valve is you can get the mechanical valves going as well, of course, which you can't do for the sutureless valves. And just proof of concept that the robot's so versatile that you can suture like it's open surgery, can't you? So that's actually a
The
real
the
advantage.
sutured valve actually was a real eye opener for me because I thought that that would have been terribly difficult, but actually, keeping your, knowing where the proline is and keeping a clear head and using the dexterity of the robot, actually, Dr. Koprivanic was able to do that very quickly. I think the cross clamp time for the sutured valve is like 70 minutes, which is, less than STS average. So really impressive, actually.
I mean, this is an incredible approach. I want you to promise me to find a video that we can put on CTSNet. I'm sure it's going all sorts of places. You've published, of course, already. We've covered that, and yeah, and hopefully, I guess that the future is. Would it be true that if any surgeons were interested to contact you, or what should a really interested surgeon do if they think this is incredible?
Yeah, they'd be very welcome to contact me. They can get me through a website. The company's a spin out from the NHS called Cardio Precision, www.cardioprecision.com, or you can approach me directly, Fraser, Fraser, at cardioprecision.com. There's quite a few surgeons in the UK want to do this, I'm pleased to hear. So we're hopefully going to form a little group together so we can get it going. And quite a number of surgeons in the US at this stage wanting to do it as well.
Well, absolutely amazing. And final point: are you still offering people robotic or just mixed minimally invasive things, or do you think it really is probably best through a robotic approach? Could you do it either way?
I think the robotic approach is going to be the way forward. We didn't really touch on this sort of subject, but one of the things that I've observed over the years, which I'm sure the other cardiac surgeons, will resonate with, is that, progressively less invasive approaches to aortic valve replacement have been progressively more difficult. So, the robot really breaks that cycle. But it's really just getting cardiac surgery has been a bit behind in getting ahead with a robot. I think a robotic surgery is definitely the way forward for the future.
Yeah, amazing. Well, congratulations, heart surgeon, innovator, and an incredible operation. And maybe we should call it the Sutherland procedure, not the Transcervical AVR. It's much less of a mouthful.
Oh, we have
I
a
think that's
fancy name for the
fabulous.
procedure, of course.
Oh well, what do you call it?
Well, we decided to call it the Avatar procedure, Avatar AVR. So Avatar,
Okay.
it's rather long-winded. It's short for Advanced Videoscopic Aortic Surgery, Transcervical Approach, Robot Assisted. So we wanted something
Oh,
that was a little bit catchy, that was sort of descriptive of what we're trying to do, but also capture the notion that it's a paradigm shift for how we do things in cardiac surgery. I hope you like it.
well, That's absolutely awesome. Well, that's absolutely phenomenal. I'm desperate to see a video of it at some stage. Maybe we'll just have to come over and video one. But well done, Fraser. Absolutely amazing. And it's just incredible to meet somebody that from, literally 40 years ago in his fellowship saw something and has brought that to reality. I think that is incredible. So from all of us at CTSNet and really around the world, congratulations. And I'm sure we're going to hear a lot more about the Sutherland avatar procedure.
Thank you so much, Joel. Great as always to speak with you. Really great. Thanks.